So hello from Sheffield. I know a few of the Sheffield gang are here this morning, and welcome to everybody else. So I'm going to talk about a few of the important issues around women's health in relation to OI. Next slide, please. So these are generally the issues that come up in my clinic, and so these are the questions that I will try to address. Is it that you don't want to be pregnant? Is it that you do want to be pregnant? Is it that you're getting menopausal and wonder what that means for your bones when you have OI? And also, I'm going to make a call that it's important to get your parts checked and engage with women's health screening. Next slide. So let's start with don't want to be pregnant. It may be that you'd like to be pregnant at some point in the future, but just not right now. Next slide. So generally, the contraceptive methods that are most recommended by the NHS are the long-acting hormonal methods, and that includes the progesterone implant, a Mirena coil which releases some progesterone hormone, or just a plain copper coil. And these methods are all very, very reliable. In fact, these methods are pretty much as reliable as having sterilization surgery, and they're all reversible. Even after these long-acting methods, your fertility would come back to normal within about 6 months of stopping to use the method. So these would generally be my kind of first choice picks. Click on, please. And then there are a number of other hormonal methods available. So that's the combined oral contraceptive pill, so the old-fashioned pill, which you take for 3 weeks and then have a week break to have a bleed, or progesterone-only pills, or the mini pill, which are taken continuously. There's now also a contraceptive patch, which is a bit more like the combined pill hormonally. And again, all of these methods are very reliable if they're used correctly. Obviously, they depend a little bit more on user reliability, because if you're taking a pill every day, you have to remember to take the pill every day, as opposed to just having an implant that lasts for several years. But if they're taken correctly, then they are very reliable, and also they are reversible, usually within about 6 months of stopping to use these methods. Your fertility would come back to normal. Next one, please. The only thing that I really wouldn't recommend from a point of view of bone health are Depo-Provera injections. So that's the injection that's given every 3 months. And the reason I know this was actually the very first piece of research that I did in bones. I did my PhD studying the effects of Depo-Provera contraception on bone health in young women. And in women who are kind of under the age of about 25, while their bones are still developing, then Depo-Provera does cause a small decrease in bone density. In women who start using Depo-Provera a little bit older, in the 30s and 40s, then the effect on your bones is generally less. But if you have other choices as a younger woman, then I would avoid Depo-Provera. I can see a question that's come in on the chat about blood clots, and that's a very good point. For some women, hormonal contraceptives aren't suitable because of things like risks of deep vein thrombosis, or things like migraine, or people with a high body mass index, and sometimes particular hormonal methods aren't suitable. But the progesterone-only methods often carry a lot less risk. Okay, next slide, please. But it is important to remember that if you're using any of these hormonal or coil-based methods, that they don't protect you from infection. They do protect you from pregnancy, but if you need protection from infection, then you need to use a barrier method like condoms as well. Next slide, please. And so there are lots of places you can get advice, and obviously people have different relationships with their GP, and if your GP is kind of helpful and engaged and quite knowledgeable about contraception, then your GP can give you some really good advice. Anybody can access their local sexual health clinic, and they're really useful because they've got a good understanding of the broad range of contraception, and that's all they do. So they can give you really good advice about your options and support you to make choices. And obviously you can talk this through with your bone team as well. If you have particular concerns about how your contraceptive choices might interact with your bone disease, then talk it through with your bone team. Next one, please. And I would recommend to you the NHS website guide to contraception. It's really sensible, it's really helpful, and it's a good place to start to look at first if you want to kind of get a bit of information, start to make some choices, and then maybe go along and talk to your healthcare professional about those choices. Next click, please. Okay, so that's don't want to be pregnant. What about if you do want to be pregnant? Next. So lots of women with OI have children, and I think it's important to say that, because I think sometimes people just have an assumption that pregnancy isn't going to be an option for them, but often it is. Not for everybody, but for a vast majority of women with OI, pregnancy is a viable option. The sorts of problems that people sometimes run into are that back pain can get quite a lot worse during pregnancy, obviously, once you're carrying pregnancy. And the loose ligaments can add to some of those problems with back pain, and especially kind of pelvic pain in the later stages. But actually, most women that I've looked after who've been pregnant with OI get through it just fine. There is a temporary decrease in bone density associated with pregnancy and breastfeeding, and that's because the baby builds its skeleton by taking calcium from your bones. So it's really important that you do what you can to keep your bones healthy. But generally, after about a year after having been pregnant, then your bone density will come back to where it was before. And so again, your bone team can give you some advice around this, and they can also refer you on to other specialists that can help give you particular advice for your situation. Next, please. And so when I talk to patients about planning for pregnancy, then I'd usually suggest to them that they have a referral to obstetrics and to genetics. And the sorts of things that obstetrics will do are have a look at your pelvis shape. And I see a question coming in about scoliosis as well. And so they can look at that to look at the shape of your spine in combination with your pelvis. And they can do MRI scans to get a better idea, and then give you advice about whether they think you will be able to carry safely. During pregnancy, we'd recommend that you have more frequent scans than standard to monitor the baby's growth. And usually what they would scan is the baby's femur length, which is the length of the thigh bone, to check how the baby's growing and see if it's showing any signs of OI or any problems with its growth. And then the obstetrics team would usually give you a delivery plan to take back to your local centre. So obviously we see lots of patients from outside of Sheffield that it's not really practical for them to come driving up the M1 as they go into labour. But our obstetrics team will kind of talk things through with you and give you a delivery plan to take back and discuss with your local team, so that you've got a clear plan and they can offer some support remotely. The other thing that's useful to do, that an obstetric team will also do, is have an anaesthetist look at your spine and look at your spine imaging. So you've got a clear idea in advance whether you'll be able to have an epidural, and that will help you make a birth plan that you'll be able to put into place. And then Judith already mentioned a little bit around the genetics options. So if we can identify the gene in you that causes the OI, then that does offer you the option to have IVF with pre-implantation diagnosis. And as Judith explained, that means that you'd have IVF, create some embryos in a test tube, and then those embryos can be tested to see if they have OI, and the ones that aren't affected can be implanted. And again, this is a really, really personal choice for couples. Some people do want to pursue that route. Some people decide that if they have a child that's affected, that's fine, and they're happy to proceed with that uncertainty. As you know, most of the common types of OI have a 50-50 inheritance. So each baby that you have will have a 50-50 chance of being affected, like flipping a coin. So if you have 4 children, in the same way that you can throw heads 4 times in a row, you could have 4 unaffected children, or you could have 4 affected children, or you might have 50-50. We'd usually recommend that your baby is seen by a paediatrician with some expertise in bone disease soon after birth, especially with families with mild disease. It can be quite tricky to tell in a young baby whether they're affected, but the paediatrician can have a look and then follow up the baby for into young life if they think they need some surveillance. Next slide, please. And so, as I've said, during pregnancy, it's really important that you look after your own bones. And so, as usual, calcium is always a good thing. We'd recommend that you get 3 portions of dairy a day if you can. So, glass of milk, cheese sandwich, and a yogurt, etc., etc. Keep active, do what you can, walk, Pilates, exercise at home to keep your muscles strong, and that will help support your bones. And be careful with your back, especially kind of once you've had the baby and you're lifting a chunky toddler. And then think about how long you'll breastfeed. And again, this is always a really personal decision. The early part of breastfeeding is really important for the baby's immune function and things, but we would ask you to kind of consider how long you breastfeed for, because while you're breastfeeding, that will be taking a little toll on your bones as well. And then once you've had the baby, we'd recommend that you have a checkup with your own bone team. And that's mostly because actually we want to have a look at the baby and meet the baby, because you'll know that when you have kids, everyone loses interest in you a little bit once there's a cute baby around to look at instead. But come along and see us and we can do a checkup, measure your bone density, talk things through and make sure that we kind of recover your bones from the pregnancy as much as we can. And I can see a question coming in the chat about IVF and where it's free. IVF funding varies a bit around the country, and other people on the panel might know more about this than I do, but the IVF funding comes from kind of the money that your GP holds, and so it can be a bit variable, and so it's difficult to advise people exactly what their access to IVF will be. So talk to your GP about that and they will know what the local funding arrangements are. Click on to the next slide, please. Just a word about bisphosphonates in pregnancy. Bisphosphonates should not be used in pregnant women, and women should not become pregnant while they are taking bisphosphonates. So we'd always advise that if you're having treatment with bisphosphonates, you should use reliable contraception. Next click, please. The reasons for that are in women who have become pregnant on bisphosphonates, there have been a few case reports of babies having minor abnormalities in their bones. And also, if you have bisphosphonates during pregnancy, the babies can be born with low calcium level, which can cause fits for the baby in early life. But that's not usually kind of something that causes prolonged harm. Next click, please. And having said that, accidents happen. Women do get pregnant while they're being treated with bisphosphonate, and problems are rare. So if you do become pregnant while you're having bisphosphonates, it's not necessarily a disaster. Talk to your bone doctor as soon as you can, and they can talk things through with you. And it's usually at least once a year I get a phone call from someone who has become unexpectedly pregnant while they're taking bisphosphonates. Next clip, please. Ideally, we'd recommend that you stop taking bisphosphonates about a year before becoming pregnant. And there's not really good evidence to know if you're planning a pregnancy maybe a few years in the future, which is the best bisphosphonate for you to be using now. And so people use pamidronate, zoledronate or risedronate, and there's probably not really good evidence to choose one over the other. Next click, please. And so I often have conversations with women who are getting menopausal and starting to wonder what that means for their bones. Next click. So all women have a decrease in their bone density at menopause. When you stop making as much estrogen, then that has an effect on your bones and everybody loses a bit of bone density. And obviously for women with OI, it's important to try and reduce that loss as much as we can. And again, this is a really kind of individual decision. It depends on what your bone density looks like, how you're looking for fractures and things. But we might use bisphosphonates for a few years around the time of menopause to try and reduce that bone loss. Or actually using HRT might be a really good option. Next click, please. HRT is actually a really good treatment for bone health. And HRT has kind of gone in and out of fashion over the years. When HRT first came into common practice, it was brilliant. We'll keep everyone on HRT, everyone will be young forever, and that's fantastic. And then about sort of 2003, when I first started working in bones, there were results of some big studies came out that showed that there might be a little bit more risk with HRT than we thought, particularly around things like stroke risk and breast cancer. And so everybody kind of thought, oh no, HRT is really bad. We shouldn't be using HRT ever. And now the pendulum has come back to a much more sort of sensible place. And that means that we think HRT for women who have low bone density and menopausal symptoms is a really good option, but we wouldn't recommend that you keep using it beyond the age of about 60, because that's where the risks start to increase a bit. HRT treats hot flushes and improves your well-being, but you shouldn't take HRT if you're high risk for breast cancer or if you're high risk for blood clots and deep vein thrombosis. Next click, please. And so my last section is just a plea to get your parts checked. Next click. This is really important, and people with disabilities can be really afraid to have health screening, and I understand this, that you're worried about how a smear test might be able to be done if you have difficulties with your pelvic shape or your spine or your legs, or if you've seen pictures of mammograms being done and you're wondering, if you use a wheelchair or if you have a spine problem, how you're going to be able to position to have the imaging done. But please don't let that put you off having your health screening. Talk to your bone team, explain your concerns to them. You can talk to your GP, and you can always phone ahead to the screening clinic, kind of explain your situation and say that you might need a longer appointment because things are going to be a little bit more awkward for you, and kind of ask what they can do and what the options are to make your screening comfortable for you. Next click. So cervical screening should be done in all people with a cervix aged 25 to 64 who've been sexually active. And so that's women, and that includes trans men as well. And if we do have any kind of trans men logged in today, it's really important that you do get your cervical screening. And you might be inclined to avoid it, but honestly, sexual health practitioners are good people, non-judgmental, open-minded. Talk to them, go get your screening done. And the screening detects the virus that can cause cervical cancer. And the importance of this is we can detect early and treat and prevent you developing a cervical cancer. If you're concerned about having your smear done by your GP, you can be referred to a gynae clinic to see somebody much more expert to find other ways around kind of making sure that it can be done comfortably and safely for you. Thanks, Corrine. Next click. Again, go to the NHS website. It's got really good information about screening for cervical cancer. Next click. And the other health screening to talk about is breast awareness. So please be breast aware, check your own breast regularly, look at the NHS health advice for breast awareness. Next click. And you should be offered breast screening between age 50 and 71, which is done by a mammogram to detect early changes again and prevent you developing breast cancer, which might need aggressive treatment. NHS website, good information again. And last one. Thank you very much, everybody, for listening.